Um, Thank you, Dr. Azzaz, for the kind introduction. Today, we'll be talking about gastroesophageal reflux disease in children with neurodisability. I first would like to actually congratulate Dr. Tariq for this, for allowing us to all meet and discuss our expertise and present our expertise in this unique group of children with neurodisability. Dr. Tariq gave me the topic of gastroesophageal reflux in children with neurological impairment. I have no conflict of interest to declare. And as we all do, when I started to prepare this talk, I started to look at the evidence and I started to update myself so that I can present to you the most up-to-date management and up-to-date information regarding gastroesophageal reflux in children with neurological impairment, to touch base on the definition, the pathophysiology, the incidence, how do we manage these patients in a case-based discussion. And what I really found is that there is lack of studies in children with neurological impairment. And there's only a few published guidelines on managing gastroesophageal reflux with children with neurodisability. And these guidelines are generally very generic, covering all children and not very specialized or specific to children with neurological impairment. So what is clear is that our management of these children is not very evidence-based and is mostly experience-based. So what's the definition? The definition was only published, or there was a consensus statement only 15 years ago in children. And in this statement, they differentiated between the physiological process of gastroesophageal reflux, where you have gastric contents moving up to the esophagus, with the pathological diagnosis of gastroesophageal reflux, which is gastroesophageal reflux disease. And it was defined as reflux that leads to troublesome symptoms. So you need troublesome symptoms to diagnose reflux disease, or you need complications such as esophagitis and stricturing. And so what are these symptoms? The symptoms can be variable, but what we need, it varies with age and it varies with the child's background. But what we can see is that there is an overlap between GI symptoms and respiratory symptoms in children who have reflux. And this is very important because the gastrointestinal symptoms and system and the respiratory system have a very strong connection. And your child does not only need to have GI symptoms, they can also present with respiratory problems. The pathophysiology. Well, in children with neurological impairment, they are unique. They are at an increased risk of reflux because they have chronic. Many of them are supine most of the time. They have scoliosis. This creates displacement of the stomach and stretching of the lower esophageal sphincter. Some of them have spasticity with increased intra-abdominal pressure, and some of them are anticonvulsants. In addition to the involvement of their central nervous system and the enteric system. And this will affect gastric emptying, esophageal motility, and it will increase the relaxation of the lower esophageal sphincter. So these children are at increased risk of reflux. And so how common is reflux in these children? Well, I'm sorry to say, we have no information about the incidence of gastroesophageal reflux in children with disability. What we have is the incidence of reflux in children with neurological disability and symptoms. So there is no published data looking at the incidence of reflux in children with disability without GI symptoms. I think this is maybe related to also getting ethical approval to do endoscopies and procedures to confirm the diagnosis. So there are two small studies looking at gastroesophageal reflux with children with disability. I'd like to think as what do you think the incidence is? You have a child who comes to you through the clinic with GI symptoms. How common is it that they will have reflux-related symptoms? How likely are they to have gastroesophageal reflux? 20%, 50%, 70%, or 90%? So there are two very small studies looking at that. One only looking at 23 children with cerebral palsy who came to the clinic with symptoms suggesting gastroesophageal reflux. They had 24-hour esophageal pH monitoring, and 70% of them have confirmed diagnosis of reflux. A slightly larger studies looking at children with neurological impairment who came with GI symptoms, and they found that 45% of these 45 patients had, which is 91% of these patients, 77% of these patients had reflux-related symptoms. And when they did their pH impedance and pH monitoring and endoscopy, 91% of these patients had reflux. So the number is quite high in these two small studies with up to 90%. So I think this is very important for us to realize and notice that when these children come to us, we have to think most likely these children have significant reflux. They are refluxing and they are at risk of developing complications from that reflux. So how are we going to manage these patients? To make the presentation more interesting, I'm going to present to you a few patients that I've seen over the years who presented to the GI clinic with symptoms suggesting gastroesophageal reflux. My first patient, this is one of the very first patients I've managed in SKMC, Ghanem. He came at 17 months of age. This boy was born prematurely at 31 weeks. He spent 2 months in the neonatal unit because he developed bowel perforation. He had resection and he has 50 centimeter small bowel. He had intraventricular hemorrhage with 2 CT scans, which showed improvement in his intraventricular hemorrhage. And he came to me because of failure to thrive. When I went through the GI symptoms, the only significant thing we could find is that he vomits once to twice a day. He doesn't have diarrhea, and he's feeding about 80 ml per kilo per day. So there's a clear lack of intake in this child. This child's not managing to drink enough. He was seen by the neurologist prior to being transferred to my clinic, and he was noted to have hypotonia. He had global developmental delay. He had hearing impairment, and they had planned an MRI of his brain. This is his weight when he was seen. This is his length and head circumference. So he was significantly failing to thrive. So this child is preterm with history of intraventricular hemorrhage. There's developmental delay, and he's failing to thrive. But why is he failing to thrive? Is he failing to thrive because he's not drinking enough? But why? Is it because he is very neurologically impaired that he cannot drink enough? Is he actually aspirating and that's why he's not drinking? Or is he having reflux and this is the cause? And generally, all these factors contribute to failure to thrive in these children. I've counseled the family. We decided that we need to increase his intake. The only way we can increase it is to put an NG tube. Parents agreed on that. We discussed upper GI endoscopy to see if he has reflux. Parents were very much against endoscopy. So we elected to empirically treat him with anti-reflux treatment, prokinetics, and a proton pump inhibitor. And since I needed to insert an NG tube, start him on feeds, we decided to admit him. So I thought we admit him and we get an MDT care. We get more teams involved, do a full assessment, full management of this child since we're admitting him. So I had a video fluoroscopy when he was admitted, which actually showed that he had slowed sucking abilities from the bottle. He was difficult. He had difficulty in oral control of the bolus, and he was aspiration. He is aspirating to nectar thick consistency, and they couldn't really give him thin because he was aspirating to thick. And then we had the MRI results. So he had severe microcystic encephalomalacia with ex-vacui, supratentorial ventricular dilatation, but no evidence of active hydrocephalus. The neurology team performed an EEG and he was found to have hips arrhythmia. So Ghanem is a complex boy. He has complex neurology, but this complex neurology interacted with his GI symptoms and caused failure to thrive. With NG tube feeding, with appropriate neurological treatment, with appropriate GI medications, we managed to improve his nutritional state. His weight went up, his length improved, and his head circumference improved. This is generally managing a child with complex neurology in a GI setting without extensively investigating this child. I've not done an endoscopy, I've not done pH monitoring, and actually we managed empirically to get him better. Nowadays, we have better facilities, better tests that can help us actually know exactly what's going on in these patients. So when we get a child that comes to us, we have to do a thorough clinical assessment, good history, good clinical examination, make sure we're not missing any system involvement, look at the growth. Don't forget your respiratory symptoms when you're looking at these children. Look for your red flag signs. We don't want to be missing a cardiac disease. We don't want to be missing a surgical problem. We don't want to be missing other GI problems and neurology. The differential diagnosis is large. These children come to us as a GI disease. We find renal disease. We find neurological disease. We find metabolic disease. We find infection. And it is our job as gastroenterologists to make sure there is no other systemic involvement. So we investigate them. The tests generally for these patients, it's not for reflux, it's to look for secondary causes. No renal involvement, no hepatic involvement, no UTI. We do imaging again to rule out other surgical pathology. We do imaging to look at the renal system, ultrasound scan sometimes, just to make sure we're not missing other pathology. And then in the right setting, once we counsel the family, we do endoscopy. We're looking for esophagitis. Sometimes it's very clear on endoscopy, and sometimes we have to take biopsies. The endoscopy looks absolutely normal, and we don't find any esophagitis except when we take the samples. We have a new technique, a new investigation. This has actually changed the way I manage these patients dramatically. A pH impedance study. This is, and we have it now in SKMC, it's a catheter that you insert through the nose, like an NG tube. You can do it at the time of endoscopy or even on the ward in the endoscopy suite without any general anesthesia. What is so special and unique about this pH probe is that impedance probe, we have two things that we can do, many things we can do to help us know what's going on with the patient. It has a gastric pH probe, so it measures the pH within the stomach. It has an esophageal pH probe, so it allows us to measure acid reflux. It has lots of impedance probes that allow us to assess if the child has reflux, And how high is the reflux going? Is the child just getting low reflux or high reflux? And this has actually changed the way we manage many of these patients. In addition to that, this machine has these buttons. So when the child's supine, the parents presses a button. When they sit up, they press a button. If the child has cough, they press a button. If the child has chest pain, so we can actually correlate if the child has reflux with the symptoms that they're coming to us with in clinic. I'll present to you a few cases that I've seen in the neurology clinic, in the MDT clinic, and in the GI clinic, where this test has actually helped me make major decisions about the patients. So I'll present Salama. I saw her a few months ago. She's 8 years old. And the question that she came to me in the clinic with is Salama having acid reflux and aspiration? Why? Because for the last year, she's had very frequent admissions with aspiration pneumonia. But Salama has autosomal dominant lysencephaly confirmed by genetic diagnosis. She has a gastrostomy with no fundoplication inserted about 3 years ago. And she's on GT tube feeding, so she's actually not having anything orally. She has nighttime feed and boluses during the day. She's not on any GI medications. She has no vomiting. So this girl has no vomiting, and I get this question, is she refluxing? Is she aspirating? And her growth is normal. I open her file, and I'm thinking, okay, is just the girl refluxing and the reflux is being aspirated because this girl is not having anything orally. I look in the file, I look at her swallow assessment, I look at her previous imaging. She's had a video fluoroscopy prior to coming to me to clinic, and it shows there's aspiration to thin, but she's tolerating thick consistency food. So if she is refluxing, she could be aspirating. So this makes me think I need to make sure she's not refluxing here. She's had imaging contrast put in 2022 through her gastrostomy, and there's no clear surgical pathology here, and the anatomy looked normal, and she wasn't refluxing when the contrast was inserted. I counseled the mother. The mother is really desperate. She needs to know the answer to this because she's been admitted frequently, needing intensive treatment in the hospital. Mother very easily agreed for an endoscopy, was very keen to do the pH impedance. So we did an endoscopy, which was normal. Histology showed some reflux changes in the lower and upper esophagus, not major esophagitis. The stomach was normal, the jejunum, mild inflammation in the stomach, and the jejunum was normal. We inserted at the same time of the endoscopy the pH impedance. We checked the position of the probes using an X-ray. So she had, this is the gastric pH, the bottom of the screen. The other pH is between the second and third blocks in the lower esophagus. So this is here will be the second pH probe. So this is detecting if there's acid reflux in the esophagus. And we get a report after 24 hours of putting the pH manometry device. And this is what we get. And we get a lot of results. But what you can see here is the bottom line shows the acid in the stomach, and she's got a lot of acid. Yellow is acid, but we expect acid in the stomach. We have the second line looks at the pH in the lower esophagus. There are some yellow, so she is refluxing. And then the other probes tell us if there is acid or non-acid reflux going up. And how high, we can tell how high. So I need to know if she's refluxing and the reflux going high. These lines here tell us when the patient is supine, when the patient's having a meal, and if there are any symptoms, so I can assess if there's a symptom correlation between the reflux and the symptoms. And I'm not going to show you the whole report, but what I can show you is that in red, this child is getting a lot of acid exposure into her lower esophagus. So she's getting increased acid. In addition to that, what's really important for me for this specific patient is that she's getting 12 episodes in 24 hours where the reflux is going up into her upper esophagus. So it is clear to me that she's refluxing and she's aspirating most likely from her reflux. So what we can do is try to raise the head of the bed. If the child's obese, reduce the weight. We can limit acid food, fatty food. Then the next thing we can do is give medications. We can try to give the feed over a longer period of time to assess, to reduce the reflux. We can sometimes give the feeds into the jejunum to reduce the reflux. And the final stage is fundoplication, and this will prevent reflux episodes. If we do any of these measures, any of these interventions, we need to reassess and see if the child responded by doing a repeat pH impedance. What is out there in the guidelines is the medications that we can use is acid suppressants, such as H2 receptor blockers or proton pump inhibitors. H2 receptor blockers work on a short term because of tachyphylaxis. There is upregulation of the receptor and they stop working. And the recommendation is to use proton pump inhibitor. This will reduce the acidity, but to prevent the episodes of reflux, prokinetics are what has been recommended to use for reflux patients. They increase gastric emptying, they improve esophageal peristalsis, and they increase the pressure in the lower esophageal sphincter. So for Salama, I counseled the mother. The mother, this child is not on any medications. We elected to start her on medications. We also slowed her feed down. Her mother is not very keen on jejunal feeding or fundoplication, and we're going to reassess and see very shortly after starting the treatment if we've improved her high reflux episodes. The last patient I'm going to present to you is Matar. Matar is 12 years old. The mother came to me asking for a pH impedance study. She said, my son gets these breath-holding episodes and he gets color changes. And he's been fine up until the last few months, but he's also coughing in the last 3 months. And she's asking, does my child have reflux? Are these episodes related to reflux? Are these breath-holding color changes related to reflux? He's known to have Dandy-Walker malformation, has global developmental delay, he's nonverbal, he has constipation, and he's had previous adrenal tonsillectomy. There's nothing significant in the history. He doesn't vomit. He feeds orally, oral pureed food. His previous video fluoroscopy showed only aspiration, microaspiration and penetration to thin, but he's fine with thick consistency. So he's okay to eat pureed foods. He was not on any GI medications other than Movicol, no PPI, no prokinetics, and he was on Pulmicort and Ventolin and lamotrigine for fits. He was growing. Interestingly, his weight gain over the last year was accelerated. He's gained a lot of weight. His height chart or length chart was not very useful to me. It was very erratic. And then I was talking to mother, do you want us to start empiric anti-reflux? Do we do endoscopy? Do we do pH impedance? As I said, this mother came for a pH impedance. So we performed endoscopy. Esophagus was normal. Lower esophagus was a bit erythematous. Stomach and jejunum were normal. The histology showed some changes, reactive changes in the lower, in the mid and the upper, the jejunum and stomach. Duodenum was normal. There was some mild gastritis. And we did the pH impedance. Again, I'm not going to go through all the results, but what we did find with him is He didn't have increased acid exposure like Salama. So although he wasn't on medications, he wasn't getting a lot of acid into his lower esophagus. We did see an increased acid exposure while he's lying supine. But what was really, really interesting, he didn't have a lot of acid reflux episodes. But what he did have is the symptom correlation. So the mother, every time he had these breath holding episodes, she pressed the button, and there was 100% symptom association probability between these breath holding episodes and the reflux episodes. And so we counseled the mother, started the patient on medications, and we said, let's see how things go with medications without any surgical treatment. So in summary, gastroesophageal reflux is diagnosed. We have a definition. It's reflux that causes troublesome symptoms and or complications such as esophagitis and stricturing. It is very common in children with neurological impairments. You have to do a full, complete assessment for your children to make sure there's no other causes. There are specialized tests that can help us know what's going on, but there is lack of evidence. We don't have much evidence, and more studies are needed to help us know what is the best way of managing these patients. Thank you very much.